and a lot of experiments, and there's just so much, there's just so much involved in finding and breaking down the human psyche before we can, come up with a conclusion. So 2013 is fairly very new for any condition, especially psychiatric conditions. So PMDD, just to help all of us understand what it is, we're going to use the name itself to come up with a description of the condition. So we have premenstrual, we have dysphoric and disorder. So from the end, disorder meaning something is out of order, something is as it shouldn't be. Yes, there is a problem somewhere. That is disorder. And dysphoric meaning an emotional state or a mental state that is simply put out of order. Yeah. Then premenstrual, for the to be more specific in this condition, premenstrual meaning before menstrual cycle, before menstruation, and that is usually the time period during which the symptoms of the condition are most prominent. Yes. So, what is premenstrual dysphoric disorder? PMDD is a severe emotional reaction to normal hormonal changes. Um, I believe everyone here has either a mother, a sister, a girlfriend, an aunt. There has to be some female in your life that is special to you in one way or another. And I think it's extremely important for each and every one of us to understand the basics of the menstrual cycle. Yes. So I'm going to go through this very quickly because it's not a very, okay, it plays an important role, but we don't need to know all these details. So menstrual cycle, on average, a female's menstrual cycle is 28 days. That is average. However, for most women, it is about 30, 32 days. And the longest normal range of the menstrual cycle is 35 days. Yes, so now in those 35 days, or for simpler example, let's use 28 days. So in those 28 days, we have the first 7 days, from so day one is when said female begins her period. So that's the very first time she starts bleeding. So we assume the first 5 days are for her period. Then from the 5th day to the 14th to the 13th day, she has no period. And then the 14th day, we assume that an egg is released from the ovaries. Then from the 15th day to 28th day, um, there's a lot of science, but basically the uterus is repairing itself. Yeah. So when an egg is released, the body expects, okay, the body is always expectant of the possibility that it might be fertilized and therefore get pregnant. So in the event that that does not happen, the cycle repeats and she goes back to day one where her period begins. Yes. So I know we are, if you get lost, please let me know. I'm just trying to simplify this as much as possible. So in in the menstrual cycle, there are so many processes that occur to ensure that it happens regularly, on time, and normally. And one of the many things involved in that process of ensuring it occurs normally is we have hormones. So hormones are basically chemicals that the body produces stimulate initiate all kinds of processes, and yeah. Yes. So the two most prominent hormones. There are many hormones, but I'm just going to simplify it and let's just use two. We have estrogen and progesterone. Now, I know they are not new for most of us. So, estrogen and progesterone have the biggest role in the menstrual cycle, especially when we are going to relate it to PMDD, premenstrual dysphoric disorder. So, PMDD, sorry, so estrogen and progesterone, when in the body, they have multiple effects on our bodies. But the difference is, the issue arises when either the levels of estrogen and progesterone are abnormal or the body's reaction to estrogen and progesterone is abnormal. So that is what we see in PMDD. In PMDD, um, the brain, which is the center of all chemical processes in the body, it's the center of everything that happens in your body. So when the when the body produces estrogen and progesterone in a very normal cycle, in very normal levels, the estrogen and progesterone will bind on the brain. Some cells in the brain will bind on the brain, and for PMDD, what happens is the normal reaction becomes excessive. So it reacts in excess to normal levels. I hope I am not confusing anyone here. If you have questions, please write them down in the chat and I will get back to you as soon as possible. So, estrogen and progesterone are our biggest players, and when the brain receives them, let me put it that when the brain receives estrogen and progesterone, it reacts extremely, okay, more than usual, more than is necessary. Yeah. So, that is the those are the fundamental basics of how PMDD occurs. And there is not a lot of explanatory science on how each and every single symptom arises. But when you look at the roles that estrogen and progesterone have in the body, and if you compare it, if you keep that in mind and also put in mind that the brain is overreacting to their presence, then some, if not most, of the symptoms are explained. And so we have now looked at what PMDD is. It's a severe emotional reaction to normal hormonal changes. Yeah. So who is most at risk of getting, of rather, yeah, getting PMDD? So it's fairly common. It's more common than we think. But then again, because of the gap in knowledge in the healthcare providers, and with it being a newly introduced, a newly recognized condition, not many books have it, not many medical books have it. So that means not many health workers know about it. But the current studies have shown that actually 6 to 10% of women are prone to being affected by PMDD. And if you think about it, that is 6 in 10 people. Sorry, yeah, I think. Is that the correct math? And I'm not sure, but so it's quite common, but then again, because of that gap, not many people are even aware that they have the condition. So diagnosing it is hard, therefore treating it is even harder. And the way PMDD presents in people is it's more of an emotional, behavioral, and mood disorder. It comes along with physical signs and symptoms, but it's okay. The condition's primary symptoms are emotional, mood, and behavioral. Now, I don't like saying that A, B, C, and D are a cause for a mental illness. Personally, I prefer to refer to them as risk factors. So, risk factors, because not everyone that has gone through A, B, C, and D will necessarily develop the said condition, but they're just more at risk of developing the condition. So we see that 50% in 50% of the cases it's hereditary. So in the event that um let's say me being female, if I am a female and I have PMDD, then there's a 50% chance that I might pass it on to my daughter. But heredity is not only in terms of genetics, because the way our brains are built is there's a lot of heredity also in the way we are brought up, the way society treats us, the way culture defines our role and sorry, our roles in society. My brain is just lagging, I'm sorry. So yes, so I have talked about that, and maybe and other people who might be at risk is females who have never used contraceptives. So this is a controversial risk factor, because we shall see later on that in some cases in treatment we use contraceptives, and in some people we discourage contraceptives. So it's a complex system, but it's more seen in females that have never used contraceptives. Additionally, seasonal changes play a really big factor on our emotional and mental state, especially for countries that have a more, defined and cyclical seasonal changing pattern, especially Europe, America, Asia, yes, the rest of the world, because Africa, we are so blessed. We are so blessed. Oh, rain and sun, it is one or the other. We are so blessed. Then we see also history of interpersonal trauma. And of course, remember, I talked about upbringing and society and cultural differences, and that those, in addition to trauma, interpersonal trauma also play a role in how our bodies react to so many other things, sorry, to these chemicals. And then stress. I do not know how else to say this, but stress is such a big issue, especially nowadays. And we the there are people who are so result driven. It is not a bad thing, but it becomes a problem when you ignore your own personal physical and mental health. So please, please, please take that time to rest, take that time to relax, take a day off. Yeah. So yes, those are the people most at risk of being affected by PMDD. um so how does it present? So we have seen what it is, who is most likely to have it, and how common it is, but what does it look like? So PMDD, our guidelines actually restrict us, because there is PMDD and there's premenstrual syndrome. And premenstrual syndrome is the old, well, sorry, yes, it is the old, it's the old umbrella term that used to envelope PMDD. But when they revised and did research, PMS was seen, they found that PMS, the definition that people had created of PMS was too vague. So they split it, and we have PMS and PMDD. So PMS is a more mild version of PMDD, and sorry, it's a more mild version of PMDD. PMS is sorry, PMDD is PMS plus the emotional symptoms. Um, I think I saw a question here.
Yeah,
What?
I had a
Yeah,
question. I don't know
yes.
if it's so soon to bring it, but like, what's the difference between like a syndrome and a disorder?
Mm, okay. A syndrome, a disorder, like I said before, is basically it. Okay, a disorder is simply put, it's trying to explain that A, B, C, and D is not the way it should be.
Hmm.
But the difference between a disorder and a syndrome is for a syndrome to, okay, to classify something as a syndrome, it has very specific a very specific set of symptoms that must be present all together to call
Hmm.
it a syndrome.
Okay.
But a disorder could be a variety of things, and the disorder, its main turning point is the oh god, the word has vanished.
I think I get the idea though. Thanks. I don't want
Okay,
to be us from the topic. Thanks.
okay, you're welcome. So yes, I was talking about the how we know what if we have PMDD or not. So the first thing we need to know is diagnosing someone with PMDD is not a one visit kind of thing. It is, first of all, it involves patient participation, and in some cases it would need a third party, so someone other than the healthcare provider, the patient. So it would need a third party, maybe a spouse, a roommate, a colleague, and they give you like let's say a book, yeah, a book, and you take daily records of your emotional state for 2 months. Those are two cycles, two menstrual cycles, and that is a must. Ideally, that is a very big must. So before those 2 months elapse, if you're to be given a diagnosis of PMDD, it would be provisional, meaning it is yet to be confirmed, but for now that is what they'll be managing. So how do you know it is PMDD? One, you need sorry, the patient or the said individual would have to be presenting with symptoms 7 days before menstruation begins. So that's 7 days before her period. The symptoms are most prominent 7 days before her period, and once her period begins, so that is bef- before day one, the symptoms have to be most severe before day one. Then after day one, symptoms begin to improve, and after day 14, symptoms become minimal or absent, and then the cycle continues. And some of those symptoms would be mood swings. So mood swings, not in our, I don't know, simplified definition, but like really um very, very drastic mood swings. So they would be very just imagine you're having lunch with someone, you're talking about something really funny, and 2 minutes later they are bursting into tears, and they're extremely sad, extremely tearful. They can't give you a very, very, like a very credible reason as to why they are crying or why they are sad. And they are really, there's a really increased sensitivity to rejection. Also, they could be extremely depressed and be filled with a lot of feelings of hopelessness. There could be suicidal ideation or even suicide attempts. They could be having anxiety attacks or panic attacks, and they could be really irritable. And those are the primary symptoms. So these have to be present in that period of time that I mentioned. And then the other symptoms, they're not really primary, but they could be present as well. We have lethargy, so they are very weak, they just lack energy. Um, so there's also a subjective difficulty to concentrate. Subjective because we can't really tell, because we're not inside their brain, their mind. So it's subjective for them. They feel like they're unable to concentrate. Then they're either sleeping too much or sleeping too little. And there could be feelings of being overwhelmed, and they could also have reduced interest in activities that usually bring them pleasure. So just imagine if an artist, for some reason, in those 7 or 10 days, does not want to paint. They do not feel like painting. They do not feel like, if it's a writer, they do not feel like writing. So it's very stressful. And the unique thing about all these symptoms is they must be interfering with their day-to-day life, especially in that time period, 7 days before the period begins and a few days after it begins. Yes, so they usually do interfere with life. And just imagine you're an artist, you have deadlines, and you just can't paint. You don't want to, it feels like a burden and all that. Then because I explained earlier that PMDD is a more severe form of PMS, so you do expect other signs and symptoms from PMS. For example, the bloating and the weight gain, the changes in appetite, breast tenderness, the swellings, breast swelling, sorry, joint or muscle pain, and so many other things. And all these things, when you just imagine putting them all together in one person, and imagine how overwhelmed and how burdened this one individual could be feeling. So that is really, really important. And because I've mentioned depression and the feelings of being depressed and anxiety, the reason for those 2 months is to help us distinguish between PMDD, depression, and anxiety, so that we do not misdiagnose someone with depression and yet it is PMDD, and we end up treating a condition over a long period of time and not having any results. So that's why it's really important for this 2 month period to be followed. Yes. Then additionally, we see that in the most severe forms of PMDD, there are patients who have, because you see, it's not every day that they are feeling like this. It is going to be for, let's say, if it's 30 days in a month, it's going to be for 15 days in the month. So for those 15 days, they're going to be in the lowest pits of their life. They're going to be so sad, so hopeless. And then on the 16th day, she'll say to you, "Oh my God, what was wrong with me? And why was I feeling like that?" You see, they have no reasonable explanation because it's not something they can control. So that feeling of being hopeless, it can later on lead to depression. So there is a possibility of having both PMDD and depression, or PMDD and anxiety. And also, because of the attitude that most people have towards mental health, there is a stigma that's created by saying, oh, you can control it, or those are hormones, you should be in control of them, or that is your body, why isn't it functioning well? And it's not something that we can consciously control. Even subconsciously we can't control this. So it's important to note that, and to remind anyone that you might find or that you might see that is in a similar situation, not only in PMDD but in any other mental health condition, remind them that it is not something you can control, but it is something you can work against, or it is something you can improve, because we do not choose how the brain reacts to these chemicals. The brain just reacts. So it's important to remember before you tell your wife that, oh, you're being moody, oh, what's wrong with you, oh, you're in your period, oh, why are you doing this, why are you doing that. Be sensitive and know that she's not in control of those hormones, but rather it's just how the body is reacting. So on that note, um how do we manage PMDD? So because of the nature of PMDD, it's not an everyday kind of condition. It's not like depression where from 1st of January to 31st of January, you would be feeling downcast. It is 1st January to 15th January, you're feeling downcast. And then the rest of the month, you are fine. And it is very confusing, not only for the patient but also the people around the patient. So psychotherapy is very, very crucial. It's the primary management that we have for any mental health condition. Psychotherapy is very, very important. And psychotherapy not only for the patient but also for the people around the patient, because they too, their emotions as well can impact the patient's emotions, and this patient's emotions also impact other the sorry the people around them, their support system. And when people know what the problem is, when they know what to expect, when they know what might happen, they would be more prepared and more equipped to handle a depressive episode or a suicidal attempt, or even just a bout of tears. They are more prepared to handle such a situation rather than someone who is completely ignorant of the condition or of the patient's current state of mind. And yeah, psychotherapy is always the best first treatment for any mental health condition. So, because we are talking about hormones, estrogen and progesterone, so maybe something small about estrogen and progesterone. So, estrogen and progesterone interact with another hormone called serotonin. And serotonin is one of the happy hormones. So, hormones that make you happy. And with the way the cycle is, the time period in which the symptoms are more likely to present, estrogen is usually higher, and yet we see that estrogen is also responsible for regulating serotonin. Now, the problem comes in when estrogen increases um, beyond threshold, or when the body, rather the brain, reacts in excess to a change in the estrogen levels. Now, when that happens, that's what causes the anxiety and the mood swings and the, okay, anger and the rage, all that. it's the fluctuation. It's not necessarily an increase beyond the threshold or the normal range, but it's the change in concentration. So when these hormones are changing, the brain reacts in excess. So in treatment of this hormone, in this in this reaction, this abnormal reaction, we can give um, contraceptives, oral contraceptives, or injectable contraceptives that contain an artificial form of progesterone, because progesterone is it has a more calming effect on our psyche, and the way it interacts with serotonin, it has a more positive impact. So the more progesterone, the more happy, the more happy hormones. So in turn, would have fewer mood swings and fewer episodes of crying and tearing and all. But yes, that is one of the treatment options we have. So if you do not take contraceptives, the other medical treatment we have are antidepressants. And it is, of course, we progress from contraceptives to antidepressants. And then if those individually are not working, we can combine them. And if even in the combination they're not working, or the condition has progressed so much that this is no longer an option, we could induce menopause. And that is simply you stop having periods. So it's either temporary or permanent. And that is entirely either up to the patient, or the healthcare provider would have to recommend it for you. And for inducing menopause, chemically it's temporary, and then surgically it's permanent. Now, the reason that we would encourage or we would advise to induce menopause is that in some cases, the depressive episodes and symptoms could be so severe where you have chronic, like over a long period of time, someone is attempting suicide repetitively, or they're having very, very provocative suicidal thoughts. And if psychotherapy has not helped, and the antidepressants and the contraceptives are not helping, you can discuss it with the patient, you can agree on maybe a plan, but usually we would recommend the menopause because it stops the production of the hormones, so it would stop the brain's overreaction to them. But because these hormones play other roles other than just on our psyche and our reproductive system, we need to replace them, but would replace them in levels that would not overstimulate the brain. So I think the inducing menopause has scared some people.
Hello, Queen. Oh, oh, okay. I
Sorry,
thought,
my network
sorry.
is jumping.
Yeah. Yes,
Um,
we are worried. about, you know, inducing menopause.
So- but inducing menopause is only and only if everything else does not work or if it is very, very severe. So, no need to worry. It is not something that is very common. Usually, the psychotherapy is intensified or the antidepressants are intensified. So, it takes a long time before we see ourselves inducing menopause. Yeah. So, questions. I think I'm done for now. And I think I can take questions if you have any. No questions?
I have a question. Um, can you hear me? I'm not hearing Queen.
We can hear you. Oh, she's back.
Okay, okay, all right. My question is, I know you've explained it, but I don't think I got it correctly. So I just want to be sure. Um, does do the symptoms the I don't know, because it's now a disorder, but you get what I mean. Like,
Mm.
like, do you start feeling these things, like from ovulation? Is that like from the explanation? Is that what it is until the time of your period? That's my question. Like, does a person start feeling all that stuff from
Okay.
ovulation till the period,
So
or
it wouldn't necessarily be from ovulation, but rather from around the 22nd or 21st day after ovulation. So ovulation is the 14th day. So you have 7 days in between. So that's the 15th day to the 21st, 22nd day. That's when we would ideally expect the symptoms to begin presenting in their most intense version.
okay, okay,
Mm,
all right. Thank you.
you're welcome. Any other
I
questions?
Yeah, I thought Gina raised her hand up.
Hmm.
Okay, I have a question. I just wanted to ask, how many days did you say it goes on for?
The symptoms.
Well, the whole what's it called? PMDD, yeah, the entire thing.
Okay. The symptoms. Okay. Um, because every female cycle is different, this
Mm-hmm.
is just an approximation using the most average cycle length. Yes, so it's not the gospel truth in terms
Uh,
of numbers, but ideally 7 days before the first bleeding of the first period.
okay, cool. Thank you. And the other thing I just wanted to say is I've never heard of this term before. I'm so glad that I learned about it today because now I'm able to attach, meaning to things that I'm going through because sometimes you're going through certain things and you're like,
Mm,
is it just me? Am I the problem? But it's just what comes with being a woman. So it's a
yeah,
good thing. And I think also for men to be able to learn about these things because so many times men just think, oh, women have a problem or like, my girl is
yeah.
like this or my sister is like this. She's like, but there's actually
Mm.
something behind, and it's the hormones that you're dealing with and everything. So yeah, I just wanted to say that. And thank you so much for a wonderful presentation.
You're welcome, dear. Yes. Men here, please, please. I'm seeing someone asking, does PMDD mean irregular periods? Um, no, but you can have PMDD with irregular periods. There are many, many causes of irregular periods that can be explored later, but um, PMDD can coexist with irregular periods. And maybe some of the causes of irregular periods can put you more likely to develop PMDD because you have higher levels of these hormones, higher or lower levels of the hormones. So, no, PMDD does not mean irregular periods. Yes, any other questions?
I had
Asha, I can't read the chat, so
no, no,
maybe you
that's
read.
okay. It's just a summary of everything you've been saying.
Oh, no, no, like I can't open my chat. I'm not yet sure what's,
Oh,
but you
okay.
can read for me in case there are any questions.
Yeah, I don't think there are any questions yet. I don't know unless someone has a question. Does anyone have a question? I had. Oh, okay. Daniel has a question.
Yes, Daniel.
Hi, thank you for the presentation. I was in a bit late.
Mm,
Um, I just have a quick one.
yeah.
Let's say, for example, you are living with someone that you suspect to be having this PMDD,
Mm,
and for example, it arises maybe when you're around them. How best are you able to go about it at home before having to seek therapy and all those other things? How best can you go about it?
okay, that's a really good question. So at home, one is being compassionate, being compassionate and understanding and patient with this person because remember, they're not necessarily in control of what is happening to them, but they're experiencing it nonetheless, and so are you. And they're actually more confused about what's happening to them than you are. So, being compassionate and understanding is a nice place to start. Then, secondly, I would say learn as much as possible as you can about the condition and in learn a lot as much as possible, sorry, learn as much as possible about the condition. And if you find yourselves in a situation where maybe the person has a depressive episode or an anxiety attack or suicidal ideation or attempt, then there are so many um, materials on the internet, especially if you go to good websites. For example, let's see, American Psychology Association has a lot of good information on how to help someone in such a situation. Um, what else? APA, that's American Psychological Association. On YouTube, there is the channel I like. I really like it because it simplifies mental health. It's called Psych to Go. You could watch a few videos and help you understand a bit more. Also, there are many other tools out there on how to help someone going through a depressive or an anxiety attack. And then it's also important to know that as much as we want to help them, a professional is always better because they have more experience, they have more knowledge than you could potentially collect from internet. So it's best to advise and encourage them to get help. And oh yeah, also getting help. The I saw this question as I was researching for this presentation. Um, who do you go to get help? Is it the gynecologist? Is it the internal medicine doctor? Is it the family doctor? Is it doesn't, okay, it matters who you go to because the depth of information varies, but it's best to begin with someone you are most comfortable with sharing the information. Although personally, I would recommend either a gynecologist or a psychologist. Yes. Yes, Daniel, you had another question.
Sorry about that, but
Oh.
I have to ask everything.
Mm.
So, um, I see in your summary something about lifestyle changes.
Mm.
Uh, should I focus mainly on encouraging this person to positive thinking? Is it something I have to I could handle using a diet? I don't know, because in some instances, some people are able to deal with their irritabilities with a change in diet, for example. Like for my case, dealing with some emotional distresses, they tell me you go and eat something, maybe you'll feel better. So I hope I'm on the right track there.
Yes, it is very true. Diet does play a role on our physical and emotional state. And also remember, it's not only, remember, because we're talking about the menstrual cycle, even other physical issues come into play. So because this lady would be menstrual cycle, she has gone through menstruation, or the body is going through menstruation, she would probably be low iron, low energy. So yes, that is very important. But additionally, other lifestyle changes or habits that you could include in the routine would be journaling, exercise, distressing, relaxing, take a day off, sleep a bit more, drink some more water. Um, there's so many other things. Lifestyle change is a very big. There's a lot in lifestyle changes, but yes, that is also one of the very very crucial parts of it. Asha, what's happening in the chat?
So in the chats, thank you very much for sharing. In the chats, there's a question if the recording could be made available, and I said yes. And they said thank you for a nice presentation. That's from Laura Biaruhanga. And I did say the recording will be made available upon request. So basically how this works is if your email address could be shared with me. I guess we refuse to like make the videos totally public because some people share information that they may not be comfortable with the general public as opposed to the mental health public. So we also want to protect everyone's safety. So yeah, and then there's another question from Laura Bahemuka, and it says, is premenopause the same as PMDD?
Okay, that's a nice one. Premenopause is not the same as PMDD because PMDD is only present in ladies that are actively menstruating. So that is ladies of reproductive age from puberty. Puberty is about 12 years now. So from about 12 to what? It also varies according to race. And okay, so 12 to about 50, 45, 60, that range. Ah, 45 to 50. Yeah, 12 to about 50 years old. Then premenopause is going to be in your late 40s there. So no, they are two very different conditions. However, we see that ladies in their menopausal season, so after 50 years old, 50, 60 years old, ladies who do hormone replacement and maybe happen to want to, deliver again in that late age, they might also present with PMDD because the brain is not, okay, the brain didn't have the same hormone activity. So reintroduction of the hormones could put them at risk of getting PMDD again, but that is a very unlikely situation. It's not very common. Yes, I think there's a hand that's raised. Yes, Emma.
Hello.
Hello, yes.
Yes, I just want to appreciate the program. Thank you so much for the presentation.
Thank you for listening and for joining
I
us.
I wanted to ask how important is it for a woman who is no longer giving birth to keep the uterus? Because I've met ladies who really want to remove the uterus, and I've also seen some doctors suggesting to ladies to remove the uterus. But when you tell other women that I have removed my uterus, they are like, "What? You've done what?" And yet you are no longer producing. You're having periods disturbing you. It's a cost you're spending.
Mm.
Maybe you have something to say about that.
Okay, so I don't know how people are going to feel about this, but technically, the uterus is, let me just call it housing for a baby. The uterus alone, without the ovaries and without the ovaries and what and the vagina, like everything else, is just the uterus in itself is housing for a baby. But removing it is more a psychological issue. If you're to remove the uterus from a clinical perspective, personally, I would suggest not to touch the ovaries because ovaries are very crucial. They produce for us estrogen, and estrogen has so many other physiological importances. It has so much more importance on the body other than just the reproductive functions. It has a lot of importance. For example, our bones, most ladies in their later years have weaker bones because of reduced estrogen. So removing the ovaries at a later stage, unless otherwise, I wouldn't recommend it. But for the uterus, honestly, if you have chosen to and there is a reason you can remove it, I would say go for it. But I don't know why you would risk the operating table for a non-clinical reason. So I guess it's up to you. I hope that answers your question, Emma. I really don't know how else to answer this question, but I think that's it. Um, okay. Are there any other questions, especially in the chat? Because I can't open my chat.
Um, yeah, there are no more questions in the chat, but I've left room for 2 more questions if people do have the. Okay, yeah. Daniel says, "Let's keep our uteruses."
Please do. I don't. Yeah.
Sorry, me, I found myself in a bio session. I'm like, wait, when was the last time I was in a biology class? Thank you, Queen, and thank you for everyone that's asking their questions.
Very
Um,
welcome.
yeah, I'm just leaving room for like any more questions. If anyone has any more questions, we're a little bit off time. I don't think we're off time. I think we're gonna officially just keep ending at 1:30 or like between 1:30 and 1:20. Oh, sorry, my time, 1:20 p.m. my time. But
Yes.
yeah, yeah. So there's a question from Roger Sekaja, and he says, what's a distinguishing line between PMDD and general life disturbances as symptoms are the same? Mood swings, irritability, dot dot dot.
Okay, that's a nice question.
Mm.
Um, the difference is in the I think the word is the cycle or the regularity of the symptoms, how often and how frequently they arise, and if there is a pattern in the symptoms, because we talked about the symptoms appearing 7 days before the period, and after the period they improve until they're minimal or absent. So in some cases it's not that the symptoms completely disappear after the period, it's merely that they minimize. So that's why in the diagnosis it's very important to have the 2 months of daily records. The word is the sorry, the way the it is called a daily rating of severity of problems. That is the self test that's one of the self tests that we have. You write down daily records of how you're feeling physically, emotionally, behaviorally, psychologically. You write down each and every single detail that's required of you. It's like a journaling guide, I guess. For 2 months, you fill it out. Of course, in relation to your cycle, so you note the first day of your period, and you begin from there until it is 2 months, and then we go through those records, and that is how you differentiate it from any other daily disturbances. Yeah, I hope that answers the question. All right. Any other questions?
So there's one question that just popped up, and I think this will be the last. Can I write the journal on behalf of my partner in case she's stubborn to get help? I would like to help her without knowing.
Hmm. That's an interesting question. Okay, so I talked about how the journaling can be done by both the patient, so your partner, and a third party, because we need to compare, because sometimes um, behavior can be subjective and we need the most objective point of view. So having both the patient's point of view in their journal and yours is important. Now, helping her without her knowing, um, from experience, keeping secrets from a lady is not the doesn't usually produce the best outcome. But I think it's best to talk to her. Talk to her. Try to be as open as you can and as compassionate in that openness as you can, because if it's something you can help her with, then it should be a bit easier to share with her. If not, no, I think it is always best to work with the patient than working individually, because you can't really know their state of mind without asking them. So it's important to talk to them. Yes. Does that answer the question, Daniel?
Yes, it does. Thank you.
Okay, you're welcome.
I guess we have come. It's very sad. I don't want to end the session, but I guess we have come to the end of our session. And I'd like to thank you very much for your contributions to the session, each and every one of you, for people that have come here for the first time, and people that have continuously been coming. And a very, very, very big thanks to, let's just send in like clapping emojis. A very big thanks to Queen for sharing her knowledge with us and sharing with us. Oh, Janet, do you have a question? Are you clapping? I know sometimes people happen to, yeah. And
Sorry, I was clapping.
oh yeah,
I'm tuning in from London. Hi, everybody.
oh,
Sorry, I was
hello.
late.
Thank you very much for coming in, and also a shout out to Queen's very supportive family. We honestly
Thank
enjoy to have
you.
you here every session. We love to see the support and love that you show Queen. And yes, thank you for nurturing such an amazing, amazing lady. She is definitely doing a lot for our generation. Yeah, so for everyone that has missed out, we are very, very sorry if you came late, but as I said, we will be sharing the what do we call again, the recording. You just share your email with us. You could share your email with Queen or whoever invited you, and I could add you to the list of people that could be able to see the video. Anyone else you think would profit from this video. Thank you once again. Yeah, I guess that's it. I guess it's time to say goodbye. We do have a session by Queen on the 4th April. She will be sharing with us on if you could give me a second, sir. Self-harm and developing coping strategies. So Queen, we're very excited to have you again very soon, and that's for the next session. Yeah. Goodbye, everyone. Thank you very much for coming.
Bye. Thank you for coming, Asha. Thank you for having us.
Thank you very much. Yes, and yes, we really do